Hello, we're joined today with Professor Simon Griffin, who is a professor in general practice at the University of Cambridge, and he was the lead author on the BMJ Research Paper of the Year, 2013, on screening for type 2 diabetes and its effect on population mortality over 10 years. And this was published in the Lancet. Welcome, Professor Griffin.
Thanks very much. Nice to speak to you.
Firstly, congratulations on winning the BMJ Research Paper of the Year. For those who are unaware of the paper, can you briefly explain what it looked at and why you chose to carry out this research?
Yeah, sure. So a lot of people were under the impression that screening for diabetes would be a good thing, and there are very good arguments why that might be the case, because it's a common condition. People have it for many years before they're diagnosed. And once they are diagnosed, the treatment can make a difference to risk of complications like heart attack, retinopathy, and so on. So there was an assumption, and indeed many diabetes organizations believed that screening the population to identify diabetes would be a good thing. And so as part of a research program addressing this topic, we undertook a randomized controlled trial where we randomized practices to screening or no screening. And in each of the practices, we identified people who were at increased risk of having diabetes without knowing it. And we took the top 25% of those sorts of people in each practice, age 40 to 69. And in the screening practices, with the practices that participated in the study, we invited them for screening, and around 73% attended. And in the control practice, the no screening practices, we didn't invite them. And then we compared mortality, all-cause mortality, cancer, cardiovascular disease, and diabetes-related mortality in the screening practices and in the no-screening practices over the subsequent 10 years. And what we found was that there was no difference in mortality, all-cause, cancer, diabetes-related or cardiovascular in the screening and the no-screening practices, which maybe suggests that the benefits of screening might not be as great as previously expected.
And Richard Lehman described your paper as one of the most groundbreaking papers to come out of general practice in quite a few years. What sort of made you want to look at diabetes?
Well, it was very kind of Richard to say that, and I appreciated his comments. I think they stem partly from a view that he and many others have that perhaps diabetes, the treatment for diabetes, does not necessarily show medicine in the greatest light, and that we've been foisting treatment and screening and so on people without necessarily very good evidence. So I think it chimed with his view and with the recent BMJ view about maybe people do better with less healthcare and less treatment rather than more. My view on it is that only about 3% of the people that were screened, even though they were in a high-risk group, only 3% actually had the condition. And so even if those 3% benefited, which some of our other data suggested that they did, then it's unlikely to make a difference on total population mortality. So in some ways, I think the result was somewhat predictable, but nevertheless, I think it was important to address it. Why was I interested in diabetes? Well, firstly, when I was a junior hospital doctor, I was given the responsibility of looking after the diabetes clinic because the consultant was frequently away. So I had to rapidly develop some skills and knowledge. And then when I went into general practice, it was at the time when some of the long-term conditions were being sort of shifted from hospital outpatients to primary care. And diabetes was probably the first one that really happened in an organized way. And, of course, diabetes is a good condition for general practice because it impacts on the whole family. It's very much a lifestyle and social condition. It involves the whole primary care team, so the nurse, the GP, the administrator, dietitians, and so on. One of the key things that determines whether diabetes care is any good in general practice is actually to do with organization and delivery of care. So it's largely about doing simple things well for large numbers of people, few of whom feel unwell. So I think it's a good condition for general practice to be involved in, and then consequently it's an interesting thing to therefore do research on in general practice. So I think that's what drew me to it initially. And the other thing is I think we can make a difference. So I think good research and good delivery of care can have an important impact on diabetes, which, of course, as you and your readers well know, is a growing public health concern in developing and developed countries.
Yeah, absolutely. And we recently had a doc2doc discussion, which was based on a Lancet paper, which was an essay that suggested that type 2 diabetes is in fact a category error. What would you say to this? Do you agree, disagree? How would you sort of respond to this?
Well, I think it was a provocative piece by Edwin Gale, who often writes provocative pieces, and again comes from a more nihilist, let's do no harm approach, which I think is to be applauded. And I do have some sympathy with the view. I regard in many ways diabetes as a social problem, not a medical problem. So the rapid rise of obesity and diabetes around the world is not a failure of healthcare. It's a failure in other areas, I think. And if we want to do something about it, if we're doctors and we just focus on the people at the extreme distribution of the blood glucose, then we're rather missing the point, because there's this sort of tidal wave of people lower down in the distribution of blood glucose who are still at risk of complications. Having said that, I do think that when I see people with kidney failure, strokes, heart attacks, amputations, they look to me like they have a disease. So I think it depends on your perspective. It depends on whether you follow Foucault and you think that disease is a means of doctors exerting societal control, or whether you believe in Illich, that society and civilization defines its own diseases, or whether you believe in Jeffrey Rose, that no one actually has a disease or doesn't have a disease, except perhaps sudden death or rabies, and that actually most diseases you either have a lot of or a little of. And it's certainly true that there is a roughly normal distribution of blood glucose in the population. And so where you put the cutoff to what a disease is and what isn't a disease is somewhat arbitrary. Nevertheless, the people who have very high blood glucose levels do suffer the consequences of that. And there are things that healthcare and doctors can do about it. So if you define a disease whereby a label that then having the label then introduces you to treatment that actually benefits you, then I think type 2 diabetes does fit those criteria. So while I have some sympathy with the view, I think that diabetes is a disease by most sociological, philosophical, medical definitions.
And finally, what do you think are the future implications of your research? What sort of impact do you think it will have on future sort of research and investigations? And what needs to change in general practice to address the management and identification of diabetes?
Well, I think one of the answers from our study is that, and from some other work we've done, is that the delay between developing diabetes and it being recognized by patients or practitioners is now much less than it used to be. So it was estimated that it was between 7 and 12 years. It's now probably down to closer to maybe 3 years. And so it may be that family doctors and their teams are getting better at recognizing the condition, and so there is no need for screening. I think the other implication is one wouldn't want to screen for diabetes on its own. If one wants to medicalize the population and call healthy people in for testing, one would probably want to restrict that to people who are likely to benefit more than be harmed. And one would probably want to assess people's risk for a range of conditions, not just diabetes. So diabetes, cardiovascular disease, kidney disease, maybe some of the neurodegenerative diseases, and so on. And the question is, who do we want to do that in? And I would argue that there's quite a lot we know about people already from their routine medical records, and that we should probably restrict testing to those who are at the upper end of that distribution, and that would be the most efficient way to do things and would minimize harm. So the current strategy to invite everyone in middle age for a health check, I'm not sure I support. In terms of future research in diabetes, well, I mean, we'll continue to follow up these populations and see whether there's some benefit in the longer term. I think the hot topics in diabetes are still around how to manage blood glucose and what agents to use. Although we have had insulin since the 1920s, our understanding of the pathophysiology and our personalization of the treatment according to each patient in front of us and what the underlying pathophysiology is still fairly basic. And so I think that's probably an area for research. But if I really wanted to advocate an area of research that perhaps isn't being done enough at the moment, it would be about how we shift population distributions of diet, physical activity, and body mass index, because that's the thing that's going to make a real difference worldwide to diabetes and related complications, as well as other things like cancer and cardiovascular disease. So we need to find out the way to get people to move about more and to eat less energy-dense food so they don't develop obesity, which, of course, is the predominant risk factor for type 2 diabetes. So that's where I think people should invest in medical science. The problem is that doesn't seem quite as attractive to medical scientists as researching the more molecular or therapeutic aspects of the condition. So perhaps it needs more support and more encouragement from the journals like the BMJ.
And there's an interesting point you made about encouraging more physical activity. I saw that NICE the other week said that they want GPs to encourage more physical activity in their patients. Do you think the responsibility to do that lies sort of quite strongly with GPs, or do you think it should be distributed a bit more widely?
Well, I think that I think putting all the responsibility for all of the travails of society and all the ills of society on GPs is unhelpful. I think that GPs are not necessarily best placed to provide advice and are not necessarily that effective at doing it. If you look at the determinants of people's physical activity levels, it is not because they don't understand that they should probably move about more. So the things that determine our levels of activity are much more to do with our environmental cues. They're more to do with how we travel to and from work. They're more to do with whether we climb stairs or use the lift. They're not really to do with doctors explaining to people and increasing their knowledge. These habitual behaviours probably don't respond so well to GPs trying to explain these sorts of things to people who already know it anyway. So I would say that it needs a broader perspective and a more nuanced approach rather than just getting GPs to tell people to move about more. Having said all that, I think GPs do have a role in health promotion, and in every consultation, as well as dealing with the presenting problem, GPs should try to address aspects of health promotion and altering health-seeking behaviour, just like they do for things like alcohol and smoking, where asking about those things and then maybe giving some brief advice does have a small but perhaps statistically significant effect. And the same would probably happen for physical activity, but the evidence is relatively weak.
Well, thank you very much for joining us today, Professor Griffin.
You're very welcome. It's a pleasure.